Well, hello. Welcome back to Conversation with Dr. Childress. I'm calling this one a Serenade with Dr. Childress because this is later in the afternoon. Um, After talking with you about, sort of the disrespect or the quality of professionals over here in the family court, I wanted to expand more on the issue of diagnosis. The professional standards of practice in the family courts are abysmal. And I know that as a clinical psychologist, and I've known that for a long time. And so there's a lot of frustration built up about the low quality of professional standards of practice. So I want to vent a little bit of that, just having to do with professional standards around diagnosis um, and what's happening in the family courts. So when I came over here about 2008-ish, the very first case, as I said, about 20 minutes into the first clinical interview, I have a pretty good indication what we're looking at. I'm suspecting narcissistic parent because the child is showing narcissistic symptoms and got a shared persecutory delusion because the child is showing a persecutory delusion. Then the next session, I confirmed it with the allied parent. I met with them, and they had a um, clear narcissistic histrionic personality pathology, and I kind of worked it all out. And then, as is the case with this pathology, because I was not uh, drinking the Kool-Aid about the child's story, the allied parent uh, had me removed from the case, manipulated the situation, so I'm no longer on the case. I contacted the minors counsel who was on the situation and informed minors counsel that I was, it's in the zone of a factitious disorder imposed on another, and nothing happened. It's like, what? Now, over in where I come from, in the hospital world of children's hospital domains, if that's if you call for a psych consult from a pediatric psychologist on a possible factitious disorder and they make a diagnosis of factitious disorder, that's child abuse, and that's removing the child from the care of the abusive parent. And all of a sudden, I find myself in a different world where I make the same diagnosis, factitious disorder imposed on another, and nothing happens regarding child abuse. And you don't do that to one of my kids. So I kind of remained in the field and started looking at how things were happening over here. One of the first things that became evident is there is zero application of knowledge, established knowledge in the family courts. And I'm talking nothing. I'm not talking, there's no discussion of even the transference out of Freud. Transference and countertransference, Freud, nothing. Behavioral psychology, applied behavioral analysis, nothing. Functional behavioral analysis, nothing. Cue structures, nothing. Nothing from behavioral psychology, cognitive psychology, nothing. Family systems, nothing. Attachment, nothing. Uh, Complex trauma, Vanderkook, child abuse, nothing. There's no application of knowledge. Everybody was just making stuff up. The parental alienation and reunification therapy, and then they just went to town making stuff up. And so when you have that level of incompetence, so in my world, I'm up working top tier professionals. Keith Nectarline, Jim Swanson, um, called in as a consultant for FEMA and DOJ, clinical director, 3 university sorts of things. So I'm used to being listened to in situations. So when I come over here and see this level of incompetence, the uh, the issue is lack of accountability, fundamentally. Uh, so I know that right off the bat. So there's ethical violations around competence, standard 2.01, 2.04, 2.03, competence issues. The What we do in response to that, if I'm coming into a staff situation where it's just a mess, I've kind of been around those situations where you have to come in and kind of straighten them up and clean up the mess. Diagnostically, what we start with is we get a simple description of the symptoms. Just just start telling me the symptoms, and because diagnosis is based on a pattern match of the diagnostic criteria of the symptoms. So you just want to start get all your staff to document symptoms. Now, in the uh, there's an approach to diagnosis and report writing, and when I was directing the clinic, I'd have professional staff, and then we'd have interns and postdocs. And the reason for the interns and postdocs is because they're cheap. We're working county funded, and that's how professional psychology works for low income kinds of situations. Is we have a few professional staff who supervise the trainees, who are really cheap or not cost don't cost anything at all, because they're getting training and supervision, and so that's sort of the trade-off. They get training and supervision, we get cheap help. And um, uh, the diagnosis would be supervised by your license. The license was in charge of the diagnosis, and there's a structure that's expected as part of that. Now, on the first intake assessment, it's 90 minutes. Now, I'll be talking just like county work. Is a 90-minute intake assessment, and that intern or postdoc is expected to return a DSM-5 diagnosis after that 90-minute assessment. So I want to be clear on that. It's a standard of practice assessments for interns and postdocs to return a DSM-5 diagnosis after a 90-minute intake assessment. Now, they can add qualifiers to that diagnosis. The qualifiers are rule out, which means it's a possibility that we're not quite sure about yet, or provisional, which means I'm pretty sure of this, but I'm still, there's some caution related to it. But if they do that, that raises an eyebrow. Within the next two sessions, they have to clear that provisional or rule out diagnosis. So when they come in for supervision, the thing I'm going to want to know is what information do you need to decide between your two possible diagnoses of bipolar disorders or schizophrenia. So what information do you need to rule one in and one out, or to change from a provisional uncertain diagnosis to a more certain diagnosis? Now, um, I'm a doctor. You may have noticed that I'm a little bit arrogant. Okay. And that's a good thing in the doctor, because our diagnosis has to be accurate 100% of the time. The reason it has to be accurate 100% of the time is because people get hurt if we misdiagnose pathology. So I was trained, intern and postdoc, at Children's Hospital of Los Angeles. I was trained with medical professionals at Children's Hospital, Los Angeles. That's the best children's hospital in the world. Okay. And when you're working Children's Hospital, the physician will come in and break a diagnosis, but the pediatric psychologist is the one who delivers the diagnosis. So when there's a difficult diagnosis to deliver, the physician will call down to the psych department and ask for a psych consult. Pediatric psychologist will go up and attend the session with the physician. The physician will tell the patient what the diagnosis is, and there'll be some crying and a little bit of intake trauma as the information is being processed. The physician will answer a couple of questions, then the physician will leave. They'll come back and answer questions later, but that's enough information from now. They break the diagnosis. Me, the clinical pediatric psychologist, will remain in the room and will deliver the diagnosis to the patient. And so we'll talk about what that is and the implications of that. So I've delivered a lot of difficult diagnoses, and that's the standard I was trained to at children's hospitals. It's a standard of physicians is that our diagnosis has to be correct 100% of the time. Okay, that's the standard at a children's hospital. We don't like 10% misdiagnosis. No, our diagnosis is accurate 100% of the time. And there's a point that comes in delivering the diagnosis where this statement is typically helpful. I'll be sitting there and we'll say, I know this is a difficult situation, but you're at Children's Hospital Los Angeles, and it's the best children's hospital on the planet. So you're in really good hands here, and you're going to get the top quality of care for this. Okay, so that's typically somewhere about 3/4 of the way through the process. You reassure them that they're going to get the best possible care because they're at the best possible facility. Now, I was then hired away to work at Children's Hospital of Orange County across town. And when I was delivering a diagnosis there, I would say the same thing about CHOC, that they are the best children's hospital on the planet, and they're going to get the top quality of care at CHOC. And both of those were true. And I can guarantee you that CHOP back in Philadelphia or MD Anderson is the pediatric psychologist there telling the patients the same thing. You're at the best children's hospital on the planet, because they are that they are the best. And at the children's hospitals, we compete for that, and that's the expectation, that you are the best doctors on the planet, because this his life is depending on you. And so if that's not in your blood to be the best, then you go work somewhere else, but don't work at a children's hospital, because the physicians there are the best. And if you're going to be a pediatric psychologist there, that's the expectation. And the expectation in medicine is that your diagnosis needs to be accurate. Otherwise, misdiagnosis hurts people. If we wind up treating cancer with insulin, the patient's going to die from the misdiagnosed cancer. And with this pathology in the family courts, the pathology of concern is child abuse. So absolutely, our diagnosis needs to be accurate 100% of the time. And so if there's a little bit of arrogance in me, it's because I've earned it. And you look at all the knowledge I know about family systems and attachment and complex trauma and everything. It's because of that obligation to have an accurate diagnosis 100% of the time. And that's a terrible obligation, a profound obligation. If I don't know what the diagnosis is, I will say I don't know. But if I give you a diagnosis, that's an accurate diagnosis. And I'm confident in that. And one of the reasons that's important is because we're elevating standards of practice over here in the family courts. And I see a lot of wishy-washy mental health professionals, even on the diagnosis side. A lot of them don't even give a diagnosis, and that's insanely problematic for them. Because if they haven't given a diagnosis, if they don't put one down, then they are asserting for a fact that they have verified that there is no diagnosable pathology present. Because if there was child psychological abuse, they'd diagnose it and tell the court, right? And they haven't diagnosed it and told the court, so there must not be child psychological abuse, right? Not even by a rule-out diagnosis. So then it's not even a possibility, right? No, but if you don't put your diagnosis, you could be in a lot of trouble, because you're saying there's no diagnosis present by omission. And so in clinical psychology, for my interns and postdocs, you always put your diagnosis on your paperwork. And it's expected to get funded out of county. You got to have a diagnosis, and it can't be a V code. It has to be one that qualifies for medical necessity. Back in the DSM-4 days, that would be an Axis 1 diagnosis. Now it's just, there's no axes anymore. So it's just one of the numbered diagnoses. In the family courts, you'll typically get adjustment disorder for the child. And that's in the trauma category. And the idea is they're having difficulty adjusting to the divorce. But the clinical question becomes why? And the answer is because one of the parents has a narcissistic borderline dark personality and is creating a shared persecutory delusion in the child. And that'll certainly disrupt the child's adjustment, give them problems here. They're doing work outside my place here, and there's a humming noise. I'm not sure if you can hear it. With the diagnosis, with the intake assessment, there's a report that also comes in, an intake report. And that report is based on a structure. Now, for county kind of work with interns, we structure it up pretty intensely for them. Oh my goodness, they are just drilling out there. It's distracting to me. I'm not sure if it's distracting to you. So I'm wondering whether I'm going to continue or just carry this on in a moment once they stop. Holy Toledo. I'm going to try to carry on for just a little bit more. So that report comes back. And now for the working county, it's a very kind of form-like structured report asking questions, and you document the information into the boxes. For something like a pediatric psychologist at children's hospitals, when I'm called up on a consult, they call down go up to the oncology division, let's say. Wow. But finally, when I'm called up to a consult, I'm going to stop and wait for them to stop drilling right outside my window so I can think for a second. They just stopped. There we go. So, so when I'm called up on a psych consult up to the children's hospital, the doctor will write an order. I'll go up, talk to his child, let's say oncology. Maybe it's a pain management thing about a spinal puncture or something going on with school or family or something. I'll call around on collaterals and collect whatever information that I need to collect, meet with the patient, whatever. Then I'll go back to my office and dictate a report, and that then gets transcribed and sent back to me and goes in the medical chart. And my report will answer the doctor's questions. And a mental health report has a structure to it. There's a typical structure it moves through, starting with the presenting problem. And that's your basic what's the pathology of concern in the situation? Are we talking about depression? Are we talking about anxiety? Are we talking about trauma? Are we talking about a child? Are we talking about adult? What is the category of the pathology? The presenting problem, identifying information is another name for that. It's typically about 5 sentences. Then the next section are all the histories, starting typically with the family history. You can do family history either from the person's family going longitudinally or the current family and then go back, but you're going to describe family history. And in that reporting, you're going to be reporting on a lot of the symptoms that will be later used for the diagnosis. Then there's social history, work history, medical history, legal history, all the different types of history. On forms, they go through it, all of them. But in clinical practice, we kind of adjust to what's the relevant situations. In my reports, I follow the same structure, but it's more higher order, more crafted, and so you may not see the structure, but it's there. Right? What's the orientation, the presenting problem, then you family history, and then describing the symptoms of the pathology that will then result in the diagnosis. Then after the histories come a summary and conclusions. That's basically where you take all the relevant, a sentence or two from different relevant sections, put them all together and create a page or so, paragraph to a page of summary of what it is. Then there's a section, DSM-5 diagnosis, and it's a very structured little section that should have a number and then a category, nature of the pathology or the name of the pathology associated with it. So let's say there's a adjustment disorder off of that, of behavior and emotions. Now, that doesn't tell you why there's an adjustment disorder. The why are the various V codes, and they're, those, they all start with the letter V. That's why they're called V codes. And they're things like educational problems, occupational problems, discrimination, legal problems, child abuse problems, spousal abuse problems, all those other factors that influence the main diagnosis. The reason the child's having an adjustment problem is because they're being psychologically abused, a V code. And so that's how the two diagnoses work together. If there's a PTSD diagnosis for this pathology in the family courts of the child, that's likely a misdiagnosis. They're likely diagnosing a specific phobia symptoms as being PTSD. A PTSD diagnosis requires criterion A. Number A, the very first one, defines the trauma as being exposure to actual or threatened death, serious injury, or sexual violence. So if my intern or postdoc is going to give me a PTSD diagnosis for that situation, they're going to need to tell me in their report, in the reporting on history, what was the threatened or actual death, serious injury, or sexual violence that the child was exposed to. Okay. And so I'm going to be looking for the V code on that, as well as the modifying diagnosis for the PTSD. Was it physical abuse? Was it sexual abuse? What was the thing that happened? If you look at the criteria for a specific phobia, however, the elevated anxiety, panic attacks, avoidance, those sorts of things, that's more likely the symptom fit for the symptoms to the diagnostic category. And so if they were actually looking at the DSM-5, they would say, I got symptoms of a specific phobia, mother type or father type. There's no such thing as a father type of phobia. There's a phobia about a lot of things, but there's no mother type or father type. The attachment system prevents that. So that's an unrealistic pathology. What it is it's a false attachment pathology, and they're trying to mimic what they think would be a trauma reaction of, frightened, phobic response of the terror. That's not how trauma shows up. Okay, if you work child abuse and trauma, that's not how trauma shows up. The child is not frightened. First off, if there's an authentically dangerous parent, if that's an authentically dangerous parent, the child will not defy that parent. No, that parent's dangerous human. But here in the family courts, I got a child saying, "No, I'm not going on visitation with you. I hate you." Go away. Whoa, no authentically abused child says that. Okay. So if there's a PTSD diagnosis over here for the child, it's likely a misdiagnosis. We'd want to identify what is the trauma criteria A that meets criteria for that. So then there's a diagnosis, and then the last section is the recommendations. And so that's your basic structure on things. Now, one of the things I see sometimes, I see a lot of no diagnosis over here. Okay, and now that's a problem. If I'm a professional, I am a psychologist who's reviewing your work. It's called, I forget what it's called, but if I'm reviewing your work, I need to understand what your diagnosis is. Okay. If I'm a doctor at Children's Hospital, continuity of care, that's what it's called, continuity of care. If I'm coming on to a case, I should be able to read your notes and read your report and know what the diagnosis is and what the symptoms are that qualify for that diagnosis, so that I can basically pick up the case at that point in time. If I don't know what you shouldn't make me guess what your diagnosis is in your professional paperwork. You should tell me. That's what that section in the report is. DSM-5 diagnosis. You say that. I see a lot of no diagnoses, or I see things where the psychologist will say the symptoms are consistent with a diagnosis of this. No, It's not consistent with what's your diagnosis. Okay, and your diagnosis needs to be accurate. We need to step up and make a diagnosis. If the child has cancer, we may not like that the child has cancer, but the doctor needs to diagnose the cancer so we can treat it. That's the standard of practice for doctors. And the idea that we aren't getting diagnoses over here just is phenomenal to me. Just phenomenal. The way we get diagnosis, the way we get back standards of practice over here in the family courts is by first documenting what the symptoms are. Because the diagnosis is going to be a pattern match of the criteria to the symptoms. So, what are we looking at? Starting with what's the category of pathology? Are we looking at ADHD? Are we looking at autism? Are we looking at depression, anxiety, substance abuse? What type of pathology? What's the presenting problem? It's an attachment pathology, a problem in the love and bonding system of the brain. We have a breach in the attachment bond between a parent and a child. It's a severe breach in the attachment bond. Well, that's first off a very rare kind of occurrence. We typically do not see that type of breach in attachment bond beyond the age of 4 or 5, because by that time the relationship is typically stable. And so, if there's a problematic attachment bond, let's see it 3, 4, 5 years old, and it just doesn't suddenly show up at 7 or 8. That doesn't happen in authentic attachment pathology. You don't see that anywhere else out there except in the family courts. So the suspicion goes up that we might have a false attachment pathology. Then the protest behavior is designed to sever the relationship, not elicit the caregiver's involvement. So it's not authentic protest behavior. So there's problematic issues surrounding the attachment pathology. However, with attachment pathology, severe attachment pathology, the only thing that creates that is child abuse. So we're looking at possible child abuse by the targeted parent, rejected parent. That's the first place we would look. That's the most dangerous situation. Is there child abuse by the targeted rejected parent that's creating the child's fear and attachment pathology relative to that parent? That's a risk assessment. We got to get in there and make sure that's an accurate diagnosis. If the targeted rejected parent is not abusing the child, if that's a normal range parent, then they cannot be producing that pathology in the child. A normal range parent, even if they're problematic, produces an insecure attachment that more strongly motivates the child to bond to the parent. Here we have a child trying to sever a bond to a normal range parent. Never, ever, ever happens. That's an impossible symptom. That's diagnostic indicator 1. Attachment suppression towards a normal range parent never happens. Impossible symptom. Problematic parents create an insecure attachment. And so that set of symptoms right there. It's an attachment pathology. It's child abuse by one parent or the other. In all cases of severe attachment pathology surrounding the child, we need to get a proper risk assessment as to which diagnosis is happening for the child. They're starting to work up again outside my place here, so I'm going to I'm gonna end this time until after they depart and come back to a discussion of diagnosis later. The central feature that I wanted to get off my chest, though, is that over here in the family courts, they don't identify what the problem is. They don't diagnose pathology. And in clinical practice, as doctors, that's what we do 100% of the time. We identify what the problem is so we know what the treatment plan is to fix it. And if the level of professional practice over here is just phenomenally bad. An intern, a postdoc, is expected to return the diagnosis after 90 minutes, add a provisional, or add a rule-out diagnosis if you want. But produce a diagnosis. 9 months, 6 to 9 months for a child custody evaluation when the possible diagnosis is possible child abuse is unacceptable. It's negligent professional practice, really. And then to return a report at the end of 6 to 9 months of forensic custody evaluation that does not have a diagnosis on it, so that we still need another assessment to get a diagnosis as to whether or not there's child abuse. That indicates how incompetent the first assessment was. If we have to get another assessment to see if there's child abuse, ask them that in cross-examination. Please, somebody ask them that. Say, there's no diagnosis of child psychological abuse here. Does that mean, is it possible there might be? They'll say, well, it's possible. Did you assess for shared delusion? No, I didn't assess for delusional thought disorder. I don't like to, pathologize people. So it's possible there might be child psychological abuse. Well, it's possible. So should we get another assessment? Well, yeah, probably. Holy cow. They just conducted a 6-9 month assessment, and we still need another one. That was just an incompetent assessment on their part. So with that, I'm going to end my talk today under duress from the workmen outside who are drilling. So we'll talk more about clinical practice in the family courts coming up. But we need standards. Standards of practice need to return to the family courts. The forensic psychologists have exempted themselves from all standards of professional practice, diagnosis, treatment plans, just everything, assessment protocols, everything, ethical codes, everything. They're just exempt. And we need standards of practice over here. We need competence back. Diagnosis guides treatments. So the treatment for child abuse by the targeted parent is different than the treatment of child abuse by the allied parent. So you need a proper risk assessment for that. And fundamentally, shared delusion. Is there a persecutory delusion present? Yes, no, maybe. Tell us. Before I leave, shut up. Before I leave, when I get an intern report, postdoc report from their assessment, from their intake assessment, I expect them to tell me in their report what symptoms meet the criteria for the diagnosis. So if the diagnosis is going to be ADHD, there are 9 symptoms of hyperactivity. If they have 6 of those, they have ADHD hyperactive type. So during the body of their report, I'm going to want them to tell me what 6 symptoms they meet for that qualify for that diagnosis. So that's what we should be looking at in these reports for continuity of care. As I'm coming in as a doctor's second opinion, I should not have to guess about what your diagnosis is or why you made the diagnosis. I'm not here to second guess your diagnosis. You're the doctor. You're the one there. If that's your diagnosis, you're the one that's calling the shots. But you need to tell me why, what are the symptoms that qualify for that. It's like the court system, an appellate judge. You need to say what the statutes were, what the evidence was. You apply the statutes to the evidence to reach your decision. You tell me what the symptoms are, you tell me diagnostic criteria, and you apply the diagnostic criteria, and that's how you make a diagnosis. And if you meet the diagnostic criteria, you have that diagnosis whether you like it or not. So if you have 3 symptoms of schizophrenia, unusual thought content, hallucinations, and conceptual disorganizations, you've got schizophrenia, whether you like it or not. So if you meet criteria for a persecutory delusion, you've got a persecutory delusion. Factitious disorder imposed on another, that's the diagnosis if it meets that criteria. So with that, I'm going to run away for the rest of today. Bye-bye.